Good evening, everyone. This is Dr. Aishwarya Mahesh Kumar. Today, we shall be discussing on local drug delivery in periodontics. Okay, it is exactly 4:57 in my clock now. We'll wait for some more time and start with the first MCQ of the day. Hi guys, good evening. This is just before I start anything on perio. All of you, please stay safe and stay home. Today, we shall be discussing on local drug delivery agents. Okay, so the main thing to know about local drug delivery is what is it, why we are going to use it, where, and as well as what are the most commonly available local drug delivery agents that we can use. Okay, that's about it when it comes to this particular topic. It is again not only theoretical, it is useful for you in the clinical perspective as well, like when to use, how to use, and when not to. Okay. So we'll just wait for 2 more minutes, then we'll start off with our first MCQ for today. Once again, a very warm evening to all of you here. Please stay safe. Just let me know if my audio is clear and are you able to see the presentation properly. I'm having my phone in hand to check the responses. Okay, any doubts, answers, do ping in the chat box. Yeah. Hi. Okay, it's clear means can we start off with the first question? We'll go ahead. See, identify the first local drug delivery agent to be put to use. Is it tetracycline, amoxicillin, metronidazole, or cephalosporin? See, a little very small snippet about the history of how LDDs came into use. We'll see the indications, contraindications, when to use and other things as we move through the topic. But the first thing is how this idea came up is because just like how we started using mouth rinses for plaque control. Okay, that was the first agent to be used for chemical plaque control as a local agent. That would be our mouth rinses. So if that could work, we could probably put something into the pocket to have a better concentration of the particular drug into the site of action or site of infection. So that's how this idea of LDD came up. And most of you are right, because most of you have given me the correct answer. So the correct answer for this is a tetracycline. Tetracycline was the first drug to be tried as a local drug delivery agent, and this was first pioneered by Goodson, okay, Dr. Max Goodson in 1979. What he did was he took hollow fibers into which he packed the tetracycline powder and tried to use it as a local drug delivery agent. Moving on to the next question. Read the options carefully, because this is a little little tricky. So first, see, where can you use an LDD? Can it be used safely in pregnancy, or in case of a drug that cannot be tolerated systemically, in case of infective endocarditis, or in lieu of periodontal surgery? Okay, this is for us to know when LDD can be safely used, when it should not be used. Okay, so the ideal contraindications and indications for LDD. Okay, so this is based on that. Just check out the options and which is the most preferred option. Let me know. I've already got one answer. Okay, like D, he's given me the answer. Yeah. One thing you should know about LDD, like we'll be discussing the indications and contraindications now. So one thing you should know about LDD is that it doesn't, and any chemotherapeutic agent for that matter, right from your chlorhexidine mouth rinse to your systemic antibiotic therapy and to your LDD, is only remember this one word. Okay, it's only adjunct. Okay, it is only adjunct. It does not by any way what to say, replace or become a substitute for any of your mechanical procedures, meaning not even your scaling and root planing. Okay, starting from scaling and root planing to complex surgical procedures, this is not in what to say, in substitute of any of the mechanical procedures. So when I say this, it means that D is not the answer. So the correct answer ideally for this would be B. Okay, a drug not tolerated systemically. Why I tell you? See, since we already know that, why I told you D is not the answer. And similarly, generally any agent or any drug, we'll be very doubtful or careful when we give it to a patient, or sorry, a person who's pregnant or lactating. So obviously A is another thing that we should be a little wary about. So let us not give. Okay, we'll not give even systemic antibiotics unnecessarily to a pregnant woman, right? So A is not the answer. Similarly, infective endocarditis is one of the relative contraindications for LDD. Okay, because of potential bacteremia, it could cause mild bacteremia. So generally, even see, we give prophylaxis prior to surgery, but that is different. But LDD in general is not much advice to a patient who has infective endocarditis. So the correct answer for this is B, a drug that is not tolerated systemically. Okay, so first, even before we go into contraindications and indications of LDD, just remember two words like I told you. First is adjunct. Okay, adjunct meaning I'm going to give it only as an additional agent to whatever I'm going to do. Okay, like for example, after SRP I place an LDD to and especially like one of the most common indications or clinically useful sites where you can apply is for a recurrent periodontal abscess. Okay, wherein see there is a lot of anaerobic infection there, which I want to control at a maximum level. Like what is the other main what to say, positive about LDD is that I'm not giving it systemically. So one thing is there is no adverse effect that the drug can cause inside the body of the patient. The other thing is it is going to give a nice concentration within the area where it has to act. Okay, so that would be the first primary indication for any local drug delivery agent. And the other thing to remember is it is not a substitute or a replacement for anything else that I'm going to do to the patient. Okay, however, I am going to underline this and tell you this. It is not a substitute, but just imagine a patient who is medically compromised and cannot go in for surgery. Okay, remember, you will definitely ask me what we are going to do in that case. We cannot do anything. At least LDD would bring some kind of effect, right? So that is plausible, but that is very rarely. Yes, I can do, because see, I'm doing that not because LDD is indicated there. I'm trying to reduce the infection there somehow, that's all. And it is only compromised therapy. And when, of course, probably the systemic whatever disease the patient has, for example, he has an uncontrolled diabetes, or he is in the active stage of some kind of malignancy, we can treat in the remission phase, right? So whenever that systemic phase comes down, I'll have to do something, a minimal thing, at least SRP to make the patient better. Okay, don't think about regenerative and resective surgeries immediately, but this could be help or addition to that case. Again, remember the word urgent. Okay, so quickly, the contraindications is straightforward. Okay, first thing is hypersensitivity. If the patient is not is allergic to any part of the drug or the agent, or even the what to say, carrier, because LDD, you just don't take tetracycline powder and put it into the pocket, right? So any agent that the patient is hypersensitive to, you will not give. Second thing is no replacement. It's not replacement, it's only adjunct. Third is pregnancy and lactation. Then patients with infective endocarditis. Finally, again, it's not a replacement for surgery or even systemic antibiotic therapy. Okay, the only difference between, only prime difference between systemic antibiotic therapy and LDD is that I want a better concentration of the drug at the pocket. The second thing is there could be certain systemic drugs or certain drugs that cannot be given systemically. For example, chlorhexidine is so popular as a mouth rinse, right? But we don't, even as an LDD agent, but we don't generally take chlorhexidine as a systemic agent, right? So see, that is exactly what it is. It cannot be tolerated systemically. So in that case, I can give an LDD, but however, it is not a replacement. If the patient is indicated for systemic antibiotic therapy, I go ahead with it. Okay, so this could be the first the contraindications and indications for our local drug delivery agent. Again, let us see, I put this from the book for you to like just brush up the concepts. I'll give you the gist and important points alone as we take the thing. Say ideally, what is the ideal requirement of a local drug delivery agent? Okay, before we see the points, I'll tell you the main things. First thing, local drug delivery. Remember two specific classifications for local drug delivery agent. One is based on how it is applied. Okay, that is either professionally applied or self-application patient. And you would ask me, what is the greatest example of self-applied LED? Is your irrigation agent. Subgingival irrigation, we give no irrigation devices. If it has a additional medicinal agent, it becomes a locally drug self-applied locally drug delivered system. The other is professionally applied, where we are going to place the LDD into the patient's this thing, okay, patient's pocket. Okay, the second classification is whether it is a sustained or controlled release or not. Okay, how it happens is, see, initially most of now the LDDs that we have now have been timed thus in such a way that it becomes a sustained or controlled release. The other one is the plain LDDs, wherein there is no, see, it's only like I said, the LDD agent is your mostly your antibiotic or the antimicrobial agent along with your carrier. Okay, the carrier is required only to make it stay in the place for a longer period of time. We need substantiation for the drug, right? So the carrier will be designed, or most probably most of them are, most common example is your lactide polymers. Okay, most things. So these polymers, what they do is they will disintegrate at a specific and controlled rate, so that the drug is released at a particular a controlled phase or a controlled manner. Okay, at a particular small amounts at a particular interval, so that it stays in that region for the required amount of time, and most commonly this required amount of time will be 7 to 10 days. Okay, so that's how the main broad classification of how, and this was given by Rams and slots. Okay, this is the major classification of how local drug delivery agents are divided into. And most of our LDDs that we talk about are sustained release now, like the more newer ones that are coming up are sustained release drugs. Okay, and what requirement do I have for that? Remember this. So with that, we'll be able to decipher what requirements are there. It has to stay in the place for a long period of time, good substantivity. Obviously, all our it should be effective against the microbe that we are targeting, and it is more like, remember, it is more like targeted drug therapy. Okay, like as if I know the microorganism, as if I have taken culture and sensitivities test for the microorganism, because I know the most common thing will be our red complex bacteria and the other anaerobes. Okay, so it has to target your periodontal pathogens. We are not giving empirical, we are just trying something out. We want a specific effect from the microorganism as such. So it should be targeted against our periodontal pathogens, and obviously all other things that would come with any drug or any agent that we give into the pocket as well. So like it should be biocompatible, it should not have any reaction, and no side effect, and obviously no good shelf life, and no systemic effects as well. We are not, it's not going into the system as much as a systemic agent would do. So obviously all these systemic side effects are almost nullified. I wouldn't say completely nullified, almost nullified. And finally, easy for us to use as well, like should be easy to like place and other things and prepare chair side if only we need a preparation. And finally economical. So this is the major indications, contraindications, and ideal requirements of what constitutes a local drug delivery system. So moving on to the next question. Identify a disadvantage of LDD. Okay, what can a LDD drug do? Okay, is it chance of super infection, systemic side effects, drug resistance, or reinfection? Okay, just think and give me the answer. Just think about what we spoke till now, okay, about systemic usage and as well as local drug delivery agent, and you will be able to find the answer for this. So can it cause super infection, or can it potentially cause systemic side effects, drug resistance in the long run, or reinfection? The answer, you will be surprised, it will be the most simple and the most straightforward thing for us. Guys, I'm waiting for your answer. I've not got even one answer for this question. Sorry, I think I didn't refresh the phone. I'm seeing the answers just now. Okay, so most of you are saying B, right? You want to say that in the long run it will cause systemic side effects, right? Uh, yeah, chance of super infection. Okay, just think. See, we'll go from first option, super infection, meaning that's very rare, right? I say I'm just giving one single agent. Here, LDD generally we don't, this multi-drug therapy and all we don't do. Okay, so this chance of super infection is much less when it comes to LDD. So it's not it. The second thing is systemic side effects. Uh, it cannot cause systemic side effects in like 99% of the cases, because that's why we are trying to give a local agent, right? We don't want to systemically drug the patient. We don't want the drug to go through first pass metabolism as well. So that's why we are placing it within the pocket itself. So again, B is ruled out. The third thing is drug resistance. Again, drug resistance is can develop for some, see, the main mechanisms by which drug resistance develops when it comes to our plaque, and when we say biofilm, is through all this anti-drug efflux pumps, okay, and the enzymes and the chemicals that the bacteria could release, partly due to quorum sensing itself, right? So even quorum sensing is capable of inducing drug resistance in what to say in the scenario. But however, that is why we are giving, see, one big thing that you have to, one big positive about LDD is that we are giving a very high concentration of the drug at the site of infection. So this drug resistance is when it tries to like dissolve and come from the tissues into the site. It's taking a longer route. Just remember a systemic administration wherein it goes to the blood and then is taken to the site of infection, right? So that route is totally cancelled. We are going through a smaller route here. Drug resistance is also much less when we compare a systemic drug to the same this thing, local drug. So the correct answer actually for this is reinfection. Okay, because see, obviously the drug will give you an effect when you're using it, but potentially, yes, the site can get or the pocket can get reinfected. Okay, so see the advantages and disadvantages of LDD. As we already like we were discussing, the main thing is it's giving a very high concentration at the subgingival environment where it is supposed to act. Okay, that is the main plus of our LDD. The other thing is it is very useful in case of an agent which cannot be potentially given into the systemic as a systemic drug. Okay, and the other thing is we are giving a smaller dose when it compared to a systemic dose. Same drug, if I have to administer systemically, I'll have to give, it has to go through first pass metabolism. It has to come get transferred to its active metabolite and start working, and a lot of see, only a percentage of the complete drug will start working when I give systemically. All this is completely nullified when I'm giving LDD. So that is the thing. The second thing is there is a very rare cases of superinfection and drug resistance. The main disadvantage is very deep pocket. Very deep pocket, you will not be able to very effectively place the agent. Obviously, because we are, see, though we say we have a perioscope and all that, placing LDD in general, we assume that okay, this is the region, this is the infected pocket, I'm giving it both buccally and interproximally, I'm going to place the drug, okay, in such a way that it is going to create a antibiotic effect within the subgingival region. But however, very tortuous furcation regions and all, it's very difficult for me to place, okay, from just through the vision without opening the flap. Okay, that is the thing. The other thing is it does not have any added effect on any other oral niche. We know about the 6 niches in the oral cavity, right? Apart from the subgingival region, you even have the tongue, tonsils, above mucosa, and the covering oral and buccal mucosa everywhere. So it doesn't give any other additional effect to anywhere else in the body. If you give a systemic drug, it would probably give an effect everywhere, but this doesn't have that extra effect. Okay, and the third thing is it is a little time consuming to place as well, and cannot be used in generalized pockets. It has to be used only in localized regions, because see, in case of generalized regions, you cannot keep placing LDD into every single pocket, right? So it has a very specific indication, specific cases where you can use. So that's the major disadvantage of LDD. Okay, and yeah, I got a query. I think Rana has deleted the queries. She's asking whether what to say, a super infection and yeah, reinfection can occur with anything else. Like we said, yeah, because as see, how much ever we do, even after surgery, if plaque and calculus come and sit in the pocket again we are going to start the disease process, right? So that is there with everything. Okay, that is there with everything, but when it comes to see, that is the, when it comes to LDD, what are the pluses and minuses? That is what we were trying to discuss in this question. Okay, so we'll now move into most commonly used LDD agents that are available for us. The first thing is this Perio plus AB. Okay, and I want you to give me the mechanism of action. Okay, there is a small again, there's a small twist in this question. Many of you will be right in this question. So remember that what is the correct action of our Perio plus AB? Is it bacteriostatic, inhibits tissue collagenase, bactericidal, inhibits neutrophil recruitment? What is Perio plus AB? First, get that, then you will be able to answer this. Yeah, Bakisha is right. Tetracycline fibers, yes. So how does it act? Most of you are saying bactericidal C. Just remember how tetracycline acts. What is the actual? It inhibits protein synthesis, right? So should it be C? Okay. Some of you are telling me B inhibits tissue collagenase. Some of you are saying bacteriostatic. Some of you are saying bactericidal. Obviously, D is not even an option. So leave D. The correct answer is 2. Okay, it is both static and inhibits tissue collagenase. Both are right. Okay, see the major effect as an antibiotic is it inhibits protein synthesis and it is a static agent, not cidal. It doesn't kill your bacteria, it stops the action of bacteria. And the second major effect of tetracycline would be to have a effect on tissue collagenase, thereby reducing the what to say soft tissue destruction that will happen at the periodontal pocket. So one of the adjunct uses of tetracycline would be as a tissue collagenase inhibitor. Okay, and this is perio plus AB is specifically tetracycline fibers. Okay, how it is and it has a when it was seen, this particular drug was seen as a MIC, the minimum inhibitory concentration was 2 micrograms per ml, and this is the clinical picture of how to place the tetracycline fibers into the periodontal pocket. And perio plus AB is a collagen fiber system. So as we know, see, it resolves on its own. That and its carrier itself is a collagen base, has a collagen base, and 2 mg the concentration of, just remember these see what percentage or concentration of the particular antibiotic is used and what would be the most ideal carrier for that particular brand drug. Okay, and this perio plus AB is available in our country itself, and most of these are available. There are a few that are not there, that's why I told you. So it is 2 mg tetracycline in collagen carrier. Moving on to the next question. Actisite contains tetracycline gel, powder, fiber, solution. First, decide what is actisite, then tell me in what form is the tetracycline incorporated into this actisite. Actisite is tetracycline. Actisite is a form of fiber, but is tetracycline present in the form of fibers in that particular LDD is what is my question. Think. Most of you are saying A and C, either gel or fiber. Actisite is fiber, but it contains tetracycline in what form? Has tetracycline been made into a fiber to incorporate it into the agent? That's the trick here, and that will give you the answer. Yeah, like I told you, most of you are going to A and C. Okay. And now I got one D. Satya is telling D. But the correct answer here is, let me tell you, it's B. Tetracycline powder into a carrier fiber is what is our Actisite. Okay, this is the age-old picture that we have of placement of Actisite into the pocket. Okay, that's a polymer, nothing else. The carrier, the fiber that we see is our polyethylene and vinyl acetate polymer. Okay, with 25% tetracycline powder which is being packed into this fiber. And how we place it is, we place it inside generally with an adhesive. Because see, this is not one of your, it degrades on its own, but it doesn't generally stay in its place much because of it's a polymer fiber. It doesn't stay in its place as such when you place it just like the agent itself. So generally a little layer of cyanoacrylate adhesive will be required, which is placed again for 7 to 12 days. Okay, so that was the trick in the question. Okay, it's again the form of the drug that is being, say, all these that we say about these carriers, no, these are all carriers, this fiber, chip, microsphere, so many things have come. All these, even nanospheres have come. Okay, all these are just carriers. They just do the job of, but they just as an understatement for these agents, because they are giving this controlled release, right? It has been timed so well. Obviously they do have an important role, because you just can't just that, like I told you, just can't take tetracycline powder or any other gel or anything and just place it into the pocket. You want some effect, you want you are doing it to have some effect, and for that they definitely, this carrier has a very important role to play. But however, the active agent is the master here. Okay, so moving on to other forms of tetracycline. We were discussing about two major forms most commonly used as fibers only, Perioplus AB and Actisite. The other thing is you also have a gel, okay, containing this serratiopeptidase enzyme. Okay, and this enzyme is incorporated to reduce the polymer concentration and also obtain good viscosity at the site when I'm going to put it into the sulcus. The other thing is it has also been tried as a bioerodible injectable solution, okay, into the with a formulation of about 10 to 20% of tetracycline into the pocket or the subgingival region. So that is about tetracycline. Yeah, good. 2.5 mg powder. Okay, yeah, we are discussing Bhargavi, we are discussing about all the most of the commonly available things, so don't worry. Now only we have finished tetracycline, we'll be going to doxy now, then we'll discuss about minocycline as well. Okay, so doxy system is a biodegradable system, one of the most commonly, I am not giving away the name here because we'll be getting, or one of you can try naming it right now. Most commonly available doxy system for local drug delivery. Okay, just keep this in mind while we are discussing this answer. Okay, doxycycline system has percentage of doxy by weight. What is the correct percentage? 5, 10, 15 or 20? Good, Sham. Actidox is the most commonly available doxy system. There is also some small point about Atridox that we should know. Okay, is it a single syringe or a two syringe paste? We'll discuss that as we go. Okay, is it a paste, gel? But what is the concentration? Is it 5, 10, 15 or 20? Most commonly used system. Most of you are saying 20. Okay, but the correct answer is 10. Okay, most commonly used this biodegradable system is 10% doxy, 33% your DL lactide polymer. Again, this is your carrier. These two are your carrier. And NMP is N-methylperidone and DL lactide is your carrier. And this Atridox system, no? Yeah, good, by the way, it's 10. So the most common thing is 10. So the correct answer would be B10. Okay, and this is available as two syringes. The polymer is a separate syringe. I'll show you the picture in the okay. Okay, it's available as two syringes. I have given away this. Okay, so tell me the answer for this even quicker. Okay, Actidox is controlled release system, single syringe, paste, or none of the above. Then I'll show you the pictures of how Actidox is being used. I'm getting another query from Bagisha, like, do any of these LDD modulate host response? Technically, yes, it has been tried to do this thing, but its effect is obviously much lesser than how much we give systemically. We'll be discussing one of the, see, we'll leave all these, see, because even your NSAIDs and other things are being classified as a host modulating agent through different mechanisms of actions. But one of the most common things, the modifying agent that has been tried as an LDD is for bisphosphonate, rather than all your antibiotics and other things. Bisphosphonates have been tried as a local drug delivery agent as well. But however, we have very, see, when it comes to newer agents, there have been a lot of newer agents that have been coming up and lot of studies on that, but nothing too solid or set in stone. Okay, they do have a host modulating effect, but how much we have to see, and whether it is really that helpful is something that we have to see. Okay, and yeah, the correct answer for this is controlled release system. Okay, so what happens is, this is the Actidox syringe. Okay, you have two syringes. One will be your doxy, that is a 42.5 mg, that is our 10% only, but contributes to about 42.5 mg of the drug, as well as your two polymers, that is the DL lactide and N-methylpyridone. What you do is, you mix the two syringes and apply it onto the, take it as a add the nozzle onto it, and it becomes, once you mix it, it becomes a yellow viscous liquid, which is then placed into the, which has the end concentration of 10% doxy, which is placed into the periodontal pocket. So what happens is, once you place it into it, it solidifies. That's why that is the function of the carrier agent. Okay, it solidifies and stays in place. That gel like kind of stays in place for the time of action of the drug, that is about 7 days. Before we move on, is there any doubts regarding these things that we discussed now? If there's no doubt, we'll move on to the next question. Is there any doubts till what we discussed now? Okay, then we'll move on. Okay, so yeah, we are coming to Arestin. Okay, Arestin is available as film, microsphere, ointment, gel. What is Arestin? First, got the answer. Okay, it's the microsphere. Okay, Arestin is minocycline microsphere. 2% minocycline into bioresorbable carriers with a resorption time of 21 days. That is the most important thing. Till now, we have been seeing only 7 to 14 days maximum, 7 to 10 days ideally. Okay, but maximum of 14 days. However, see, this has a good this thing of 21 days, and the GCF this thing is able to be there in the what to say, at the site of action. Because GCF is the, you need the drug at the GCF, right? So that's 2 weeks or more. Till now we have seen only 10 days. So this is one of the most sustained and controlled release acting agents. Okay, so moving on to the next question. Minocycline ointment is marketed in the name of, okay, just one info here. We had few options in the previous question, right? Minocycline is available as almost everything. The ointment, gel in the form of microspheres, and the ointment is called what? Is the next question. There's another marketed name as well. Okay, so if anybody knows, please give me that name as well. And it's not been represented in this question. Yeah, most of you are right. Very good. It's Perioclin. It's also known as dentomycin. Okay, Perioclin is in Japan, dentomycin in Europe. Again, 2% minocycline only. See, one thing about minocycline is the concentration is 2% minocycline in the carrier polymer. Okay, matrix of hydroxyethyl cellulose and aminoacyl methacrylate, triacetin, and glycerin. Just remember the most commonly used polymers and which kind of polymer is used where. Obviously, when it comes to all these collagen based LDDs, you will know that the carrier is collagen itself. Okay. Moving on to the next question. Alazole contains what? Minocycline, metronidazole, chlorhexidine, tetracycline. This should be pretty easy. I think you guys will be very fast on this. Yeah. Yeah, Lysol is metronidazole. Good. Okay, good. Lysol is metronidazole, but what concentration is the thing that we need to know and in what form? Okay. It's an oil-based gel consisting of 25% metronidazole in a matrix of glycerol monooleate and oil, most of oil-based kind of gel. Okay, and it is placed subgingival with a syringe only. Okay, and 25%, 2% minocycline, 10% doxy, 25% metronidazole, and 25 mg of tetracycline for your Actisite fibers. Okay, remember the concentrations, remember the drug names, the probably the brand names that are being used, and what is the generic name of the drug used in each agent. And the next thing is Metrogene. Again, Metrogene is metronidazole, as the name suggests, but it contains one specific type of collagen. Is it type 1, 3, 6, or 12? Yeah, Bakisha is right. Uh, Even before any of you try to answer this, I've given out the answer. Yeah, most common type of collagen, obviously. So, metrogene consists of type 1 collagen as well. That is a combination of collagen, bovine collagen type 1 in metronidazole. But it's 5% metronidazole. That's what you should note here. Okay, 5% metronidazole in human collagen, and it has been used as a gel into the subgingival region. The next thing is periochip. All of us know about periochip. Okay, you just have to give me one new point about periochip. Okay, is it triphasic, monophasic, biphasic? How does it act? And what is periochip? Okay, it's given in the packet. Chlorhexidine. We know it's chlorhexidine chip. Yeah, good. It's chlorhexidine chip. And we also know that they generally say, baby nail shape of that, see, or bullet shaped. You can even see in this picture that they have represented. The chip looks like a bullet or in the shape of a baby's nail. That's why the particular representation as well. So, how does the drug get released? In how many phases? Is it just 1, 2, or 3? That is mono, bi, or triphasic agent. Yeah, good. Uh, 4 into 5 into 3.5. Yeah. This is one thing that we don't know. That's why I put it up as a question. We all know periochip. We all know how it is being placed into the pocket, how it is used. But the thing is, This is one point that we probably would miss. I already got one answer. Nikita is telling C, so you guys have to think and tell how it works. Guys, I'll just wait for some more time for any of you else to try, then we'll see the correct answer. Okay, the fight is between B and C. It's either monophasic or biphasic. Leave the triphasic, leave none of the above. Okay. Okay. Can I tell? It's biphasic. Okay. What happens is it releases in 2 intervals. Okay. The correct this thing is, yeah, because Rana has already given the dimension. So leave the dimension again, and we know it's chlorhexidine 2.5 mg. Okay. What it does is, first, it releases almost 40% of the agent within the first day itself when I place it into the pocket. The rest 60% is released in the 7 to 10 day interval. Okay, that is why this chip is a biphasic chip. Remember that. Everything else we already know about chlorhexidine and perio chip, including its shape, dimensions, concentration. The thing is, it has a release over 2 specific intervals. One is most of it, that is about 40% of the drug is released within the first 24 hours or the first day. The rest is split in a controlled manner over the next 1 week or 10 days. And this is how you place the chlorhexidine chip into your periodontal pocket. Moving on to the next question. The matrix for periocol is, again, this is too straightforward, but still. Is it collagen, polyglycolate, gelatin, or polygalactin? And what is periocol? That also you should tell me. What is the active agent of periocol? Periocol. Col. Good. Collagen. Okay. Periocol. Again, what is chlorhexidine? Okay, 20% chlorhexidine solution, that is 2.5 mg of chlorhexidine in a 20% collagen membranes. One of the drugs we are incorporating into collagen membranes. Okay, there is also one of the, I wouldn't say very recent, but one of the 2013 studies done by one of our Indian periodontists, Dr. Surendra, wherein they have incorporated 5 different antimicrobial agents into our periodontal membrane. Okay, they have incorporated 5 different antimicrobial agents into our, and it is being timed to release one particular agent at one particular time when the membrane stays in place for our regeneration or GTR procedures. Okay, it has been tried. It's a study, but like what to say is, it has not been commercially come into use, but such a membrane has been tried. So one of the things about periocol is it's a membrane. So when we are doing the surgery, I'm going to incorporate antibiotics into my membrane to probably have an additional effect at site when I'm going to achieve or target regeneration. Okay, so that's about periocol CG. And the, I think, last question for the day. The depicted LDD, one more thing. I think this is not one we commonly find in textbooks. Again, close site, so chlorhexidine. So tell me the this thing, carrier or the polymer which is based out of this agent. Again, as a gel. Okay, it's a gel. You can see the picture only. Chlorhexidine is a chlorhexidine gel, but is it incorporated with which of the following agents? Cytosine, gelatin, xanthan, or none of the above? Yeah, Varsha is telling me xanthan. Gelatin. Any more guesses? Most of you selling gelatin. Okay. But I already got the right answer. The correct answer is A, xanthan. Okay, it's a xanthan type of, xanthan is a saccharide polymer. Okay, it's a xanthan type of gel. Like I told you, 1.5%. Okay, see, the even the agent you can find mostly by its name only. Okay, and the sometimes you will find the, like periocol, no, you'll be able to find the this thing, what to say, carrier with the name of the drug. But the concentration is where we tend to, like, we need to remember the values. So it's 1.5% gel of chlorhexidine and a xanthan substrate. The other LDDs that have been tried are, these are all new things that have been tried and are coming up. Okay, ofloxacin, spirulina, 1% alendronate. Okay, that is our bisphosphonate. Like we were talking about host modulation, right? They have tried 1% of alendronate gel into the pocket, and this was done in Bangalore by Dr. A.R. Pradeep sir. Okay, so the one of his, not even one, he has more papers on this than anybody else, I think. So that's one. Bisphosphonates is one of the agents that have been tried. Obviously statins as well. That's again his forte. Then 0.5% azithromycin or clarithromycin. Then all your natural agents such as aloe vera, neem, turmeric, propolis, everything has been tried as a gel, or mostly as a, most of these as a gel or an injectable form. Okay, none in what to say, your chips or your fibers. Okay, most of them have been tried in your injectable or gel forms. But however, and they seem to have an effect. But whether it can be used as the go-to drug is something that we are not very much aware of. Okay, and anyways, it's an adjunct. LDD itself is going to be an adjunct for us. So the only thing that you should actually remember about local drug delivery agents is that clinically when to use and where to use. Clinically, again, let's say, it's a clinical point. Try to use it in single pockets or fewer pockets, not your generalized periodontitis cases. Okay, where the infection doesn't seem to keep resolving at all. Remember that the infection is not responding to much of your, even in kind of, as we say, no, when I'm telling this, no, refractory types you can try. Okay, so try to use it in a place where the infection is not trying to be getting controlled with your normal agents. Okay, and second thing is, first is that, okay, second thing is, try to use it in a place where you know that the infection is so severe and the pocket is active, and that you need a good concentration of the drug at the site of infection. So remember this, this is the primary indication of where I'm clinically going to use LDD, because all that we spoke about, the concentrations, the agents that are available, there are so many other agents. I have just put up few examples. So many other agents that have been tried, so many things that you can do when it comes to LDD. But clinically, one thing is, where I want to do it is the most important question. Okay, so target only specific very deep pockets as well. It will give an effect. Okay, how it has to be placed properly, that's a different issue. But target very deep pockets, target areas where infection is not subsiding very easily. Okay, in such areas. Second thing is, obviously, when you need some kind of, like I said, see, it's not a substitution for your surgery or systemic antibiotic therapy or even your SRP. Okay, but whenever you need some kind of effect, but however it is not achievable through any other means, like I said, a patient who is having systemic disease and cannot undergo surgery, and for the moment he is not able to even undergo scaling and root planing, you can try this, okay, as an adjunct, and then go ahead with, when the patient's systemic condition stabilizes, you can go ahead with your surgery, or even at least phase 1 therapy to keep the disease at bay. So that is the primary indication. Again, primary contraindication is just like how we tell for any other thing, okay. Pregnancy and lactation is a definite contraindication. Remember, infective endocarditis, we don't use LDD because we don't want bacteremia. Potential bacteremia can occur because of the reactions at the site of the subgingival deposition. So we don't want. So infective endocarditis we don't use, and we don't use it as a replacement for anything. Primary thing is your mechanical debridement, especially phase 1. Even surgery is not possible without phase 1 therapy. So it's not a replacement for anything. Okay, so that is the take home points. The other, that is the major indications, contraindications about LDD. The other thing is, just remember, because for the exam point of view, even for if you are taking any of your final year exams or anything, as well as your NEET, as well as clinically, remember what is the concentration of the drug, which drug you want to use. Okay, most of these can be tried, because most of these, see, there is no as such, okay, as such, from what I have seen, there is no specific thing to say in this pocket I want to use only tetracycline or chlorhexidine, because the thing is, all those agents that we discussed are very effective against our periopathogens, because that is the thing that we wanted in the end. That's the thing that we want. So they are effective against periopathogens, so there is no one drug is better over the other kind of theory in this LDD, but just remember when to use and how to use and where to use. Enough. Okay, so generally there's no, it's not like if it's a 5 mm pocket, take use chlorhexidine chip. If it is a furcation involvement, put tetracycline. It's not like that. So just based on how the availability and what you want to achieve, you will be able to decipher what you want to use. Is there a way to see exactly what community of colonies are predominant in a disease condition? Like, yeah, one of, see, all your, we say no, omics, all your microbial techniques can see, starting from the very basic Sokransky's DNA hybridization, all your microbial identification, you will be able to take the sample, or what to say, sample is only plaque, no? So you will be able to take the sample from the subgingival site and analyze it for your array of microorganisms at that particular region. Okay, that is definitely possible with all the advanced sequencing procedures. Okay, not only your hybridization procedures and simple identification procedures. Culture is gold standard. We always say, no, we always speak about microbial culturing as gold standard for identifying the microbe. But however, you have all the 16S RNA and other advanced sequencing techniques that would give you the correct idea of what is there within that particular pocket. Yes, you can find out, but whether I want to find it out for placing LDD is a question. Clinically speaking, I am not talking about research perspective. Maybe research perspective, we can try this out. And sequencing is done for even the entire oral microbiome. Okay, so that is there, but still for LDD, if I want to see, do I just take the sample, go and see which microbes are there in place, is a good idea, but clinically, do we do that is the question. Okay, we can see the to answer your question, Bhargavi, we can see through sequencing what is the exact composition of that particular thing. And why we generally say is, obviously, see, all these new microbes have come up. So many other new periodontal pathogens are being discovered day by day. Okay, starting from F. to so many other things. But we still, over years, stick to 3 red complex bacteria, and especially our PG, which is our keystone pathogen, because it is able to modulate, we have discussed this already, like in plaque anyways, it's able to modulate host response in a way, such a way that host also is not able to do anything for it. It tries to increase the concentration of other co-pathogenic bacteria. So the main target for us should not be single organism as well. That's also true. Should not be just a single organism, because we have an array of periopathogens at the site, for whatever site it is. Okay, so tell me if there is any other query. And assuming that all these are there, and assuming that this is not assumption, it's a fact that all of these LDD agents are being effective against most of our anaerobic spectrum, and those that are most commonly seen in our sites, we go ahead with directly using them. Okay. Any other question? Any other doubts, guys? No doubts means we can end the session for today. Okay. Thank you all for being there. Stay safe and keep learning. Okay. Happy learning. Okay. For clinical use, but we didn't do this practically, not feasible. Anything that, see, research on any new research is based on one single idea, right? So like what you say is correct, but is it feasible for us clinically is a big question. Okay, that is where the thing lies. But however, you can sequence and see, and sequencing they are not doing for one single site. Okay, generally in the US, where maximum of all this research takes place, no, they are doing sequencing for the entire oral microbiome. Okay, it is possible in India as well. I'm not saying it's not possible in India, but basically that's where you will get more amount of information rather than just a single site. Okay, they're doing complete oral microbiome sequencing and finding out what concentration is there in the what to say, what kind of species is there, and it's supposed to be what to say, specific to, just like our fingerprint, no, when it comes to this microbiology, it is supposed to be specific to the individual. Whole microbiome is specific to the individual. That's what they have found. Okay, and thank you all. Okay, there's no other question. Thank you so much for patient listening.